Hello, everyone. So I'll be going through the biopsychosocial management of chronic pain. So you listen to the anatomy of pain, pharmacology, acute pain, and neuropathic pain. And this would be a more of a practical approach to managing chronic pain. And as part of your curriculum, it states you guys need to know the importance of the biopsychosocial aspects of pain. So biopsychosocial seems to be a fancy name. So what we are doing at the moment is a biomedical model. Biomedical model is a traditional approach for treating any medical condition. In the biomedical approach, every disease process, it states, can be explained because of an alteration in normal function. Every disease process is caused by a pathogen, an abnormality, or an injury. And when you administer a treatment, it should terminate the disease and resolve the disability. So this is the biomedical model. And when you apply the biomedical model to pain, the focus would be primarily on the biological component of pain or the pathophysiology, and the mind and the body are treated or seen as separate entities. And pain is seen as an exclusive process to the sensory nervous system, and the disease as a purely mechanistic biological process. The biomedical model can sometimes be applied to acute pain, but not to chronic pain. If you try to apply the biomedical model for chronic pain, it leads to unsatisfactory outcomes and it increases the suffering. So what we have got is a holistic approach, biopsychosocial approach to pain management. Because in patients who got chronic pain, they've got physical symptoms, of course. So they've got biological components, but they've also got psychological components, behavioral components, which we're going to see in detail in the next few slides. So the biopsychosocial treatment model helps the patients deal with the issues which are caused by the condition and not just focus on the physical aspects of their pain. So the biopsychosocial model historically was postulated by a psychiatrist, George Engel, and it includes all the three components, the biological, psychological, and social components, they're all interlinked. And the onion skin model is also used to depict the biopsychosocial model. So here you see the nociception. This is the biological component causing pain. And when there is pain, the patients perceive it. These are the symptoms which the patients perceive, which cause psychological distress, which in turn causes illness behavior, which is going to affect the social environment of the patient. Again, we'll go through a bit more in detail in the next few slides. All the slides would be available to you guys after the presentation. And if you have any queries, feel free to put it in the chat box. We're going to go through a case study just to explain how things can be. So imagine a 30-year-old lady who's happy in a relationship, who's been married for 6 months. A week ago, she had a road traffic collision. And after that, she's been having neck pain, back pain. She's gone to a GP who has said it's just a trivial whiplash. It should get better in a few weeks. So when she saw her GP, what type of pain do you think she was suffering? Would anyone mind unmuting their microphone and answering in the next few slides, please? Anyone want to answer? What type of pain is the patient suffering from?
Can be neuropathic or maybe traumatic, somatic.
Yep. So we just broadly, I would say it's an acute pain. It could be neuropathic, but broadly, it's an acute pain because it's just a week since the injury happened. So now let's fast forward to 4 months later. So her trivial whiplash is still there. She still got pain. And by 4 months time, she's still taking painkillers, paracetamol, ibuprofen, a couple of other drugs, but she's saying the pain medications are not touching the pain. She cannot sleep. She has lost her appetite. So what's happening now? What type of pain is this now, broadly speaking?
Chronic now?
Yep. So of course it's chronic pain now. So the patient's had a nociceptive injury, and perception has changed. She's not able to sleep. She's not able to have proper appetite. So she's got chronic pain now. And fast forward a bit more, a few more months, 10 months after the accident, she's now made redundant. She's not able to work. An insurance company are delaying the settlement for the accident. She's irritable, she's feeling depressed. Her fiance left her. She's no longer saying she's no longer the person she was. So how would you describe the deterioration of condition now? So I'd answer this. So this is a psychological distress the patient's having. So we started with a simple pain, neck pain, back pain. Patient started developing perception of pain affecting her daily activities, and now she's having psychological distress due to the pain. And coming to 18 months now, she has been to specialists in 3 hospitals, multiple investigations, and she's confined to her home. She's having fear of making her pain worse, and she's not as mobile as she was, and she doesn't want to see any of her friends. So the problem here is she's displaying illness behavior. So she had pain, she perceived it, she had some psychological problems. Now even her behavior is changed. She doesn't want to make as much movements or see as many friends. And because of a change in behavior, a social circle has changed. She's not got much friends, she's staying away from her friends. So at this point, if this patient was treated using the biomedical approach, misfortune would have been a straightforward patient of chronic pain. So it's just looking at the surface of the problem. But only when we apply the biopsychosocial approach, we go through each of these layers. So that's the importance of looking at chronic pain in a biopsychosocial approach. So what are the other ways this patient could have manifested a pain condition? So this is not only to this patient. Any chronic pain patients, neuropathic pain, diabetic neuropathy, back pain, headache, any pain, any chronic pain can manifest in the following conditions, in the following ways. They can be angry, they can have catastrophic thinking, the beliefs may be different, depressed, the coping strategies might be helpful, may not be helpful, they might be anxious. So going through them in a bit more detail. Anger. So anger, it's commonly seen in people with chronic pain. Usually anger is self-directed. They can be angry towards their employers, they can be angry towards their family members and the healthcare system in general. And the degree of anger to some extent is related to the degree of pain intensity and the degree of perceived interference of the pain in the patient's life. Catastrophic thinking. So what is catastrophic thinking? It's fearing the worst, extreme negative thoughts. Once the patients have chronic pain, they've got psychological changes, they've got illness behavior, they can or they may interpret even minor events as major disasters, and which leads to increased pain reporting and poor treatment outcomes. Depression, again, 50% of chronic pain patients may have depression, and the majority of the cases, depression is more largely a consequence of the pain condition rather than the cause. Coping strategies. Coping strategies are self-management strategies. They can be passive or active. Passive coping strategies is depending on others for pain control. It involves restriction of activities and it increases the pain and it increases depression. For example, using carers or relatives to help them with daily activities and they're restricting their own activities. So it forms a vicious cycle. They're doing less and less activities every day and just going to increase the pain, and they're going to feel they're not able to do their daily activities as much they were able to do. So it's going to increase the depression as well. Active coping strategies, on the other hand, involve maintaining the activity despite pain, and this is associated with a better functional outcome. Chronic pain patients can have anxiety. It increases the perception of pain. Abnormal beliefs, the beliefs which the patients have got a profound effect on the clinical outcome. One of the abnormal beliefs is fear avoidance belief, which restricts the physical activity. For example, in a patient with low back pain, if they believe that the pain is a sign of injury, then they're going to limit their activity, which results in pain deconditioning, increases their disability, and it's going to worsen their pain. So to put it in a diagrammatic way, the patients had an injury, they're experiencing pain, and acute pain, now it's changed to chronic pain. And because of poor psychological coping mechanisms, if the patients start catastrophizing, they start to fear the injury, and then they avoid any physical activities, they're going to disuse, they're going to go into depression. It's going to increase the pain experience. On the other hand, what we want the patients to do is not to fear the pain, confront the pain, which will ultimately lead to recovery. So this is the concept, one of the concepts of pain management programs, which we'll go through in the last few slides. So coming on to the flag system. So you've seen, we've all heard of red flags. There are a few more colored flags. These are predictors of certain chronic pain conditions or management. Going on to red flags are predictors which suggest that there's a serious underlying medical condition which could be the cause of pain. So patients come to the pain clinic, it's got chronic back pain, but if in your history or examination that you find any of these red flags, then you must think, is the patient really got chronic pain or is there an underlying serious medical condition? So if the patient gives history of fracture, trauma, if they're too young or history of cancer, steroids, immunosuppression, or gallbladder dysfunction, you just need to go in a bit more detail in their history or examination, or you may need to order a few investigations to rule out the patient's not got any underlying medical condition which can be serious or which could be treated. So we don't want to send the patient home with just painkillers or book them for an injection when they've got a fracture of the vertebrae, which can become unstable or deteriorate in the next few days. So that's the reason we're talking about flags, red flags. Yellow flags are coexisting factors which are obstacles to recovering from pain. We talked about a few yellow flags in the previous slides, like abnormal belief. So believing that the pain is harmful, activity is harmful, or adopting illness type behaviors, they're all yellow flags. And blue flags. Blue flags are socioeconomic perceptions which contribute to delayed recovery. For example, fear of unemployment, if they're dissatisfied with the job, poor relationship with other employees, they're all blue flags. And black flags, they're different from blue flags. So as I said, blue flags are socioeconomic perceptions of the patient, and black flags are socioeconomic characteristics of the system. So they can be organizational black flags or system black flags. For example, low income, low socioeconomic class, lack of rehabilitation policy from the employer, lack of support from the employer. And lastly, orange flags. These are mental health related factors which are going to influence pain. Presence of a psychiatric illness, personality disorder, post-traumatic stress disorder, high level of distress or depression. So these are the types of flags. There are quite a few flags and examples. As I said, you'll be getting the slides later on, so you can go through them again. And we're going to talk about gains. Oops. Okay. So primary gain, it's a psychological mechanism by which the patient is defending his unacceptable effect. So patient's got chronic pain. He's also got depression. So the patient doesn't want to focus on his unacceptable effect like depression. He doesn't want to say he's depressed. So he may say the chronic pain is causing the depression, and this helps him avoid self-blame. So this is a primary gain for the patient. And a secondary gain is again for the patient, but in secondary gain, there's an external reward for the sick person. For example, diminished work responsibility or increased personal attention because of chronic pain. And tertiary gain is for a third party, third person. Because of a person's illness, someone other than the patient is getting benefited. For example, a wife can benefit from a chronic pain of a husband because she's able to take over the finances if she wasn't allowed to do so previously. So the final set of slides are going to go through the pain management program. So we learned about the biopsychosocial approach. So we can use this approach when a patient's come to you in the clinic. But in the pain clinic, you just got 40 minutes to discuss the history, examination, investigations, and come up with a treatment plan. So what we need is a multidisciplinary approach, a psychologist who can help about the psychological aspects of the pain, social aspects of the pain, and a physiotherapist who can help with the activities or abnormal beliefs of the patient. So this multidisciplinary approach is practically seen in pain management programs. So they are the treatment of choice for chronic pain. It's backed by quite a lot of evidence. It's guided by cognitive behavioral therapies, and there's a multidisciplinary team. And the aim of any PMP, pain management program, is to improve the level of function and achieve the goals which the participants value. And it also addresses the physical, social, emotional aspects of the health, and it's using a multidisciplinary team. One point to note is the aim is not to decrease pain. It's to increase the level of function. So even with the same amount of pain, the function can improve. That's what we're aiming. And with the right psychological uh, teachings, the perception of pain can change. So that's what we want. And patient selection, not everyone can attend or can be going through a pain management program. It should have, the chronic pain should have a significant impact in their life. There should not be any discrimination regarding age, literacy, litigation, or whatever judgments of motivation we think they've got to come to us. But there are some contraindications, like if there's rapidly progressive life-limiting illness, a current psychotic illness, or significant cognitive impairment, there are contraindications. And what usually happens is a patient comes to the pain clinic, you assess them, and you feel one of the treatment options is to send them to the pain management program. You write a referral, and before they attend the actual program, there will be an assessment day. So they'll get a telephone call, and they'll be attending a one-day pain management program session in which they'll be given an overview of what's going to happen in the next few days and see how they feel before going on to the full program. And what happens exactly is we identify the unhelpful thoughts of the patients, and we try to give graded activation and graded exposure to what the patients feel as threatening activities, reduce their avoidance behavior, increase their activity in normal life, enhance acceptance and psychological flexibility. Other things which we do is spacing of activities. Physiotherapist usually helps it, and managing flare-ups or setbacks, how to communicate with family and friends, sleep hygiene, and education. What's pain? Why does it happen? Why does acute pain change into chronic pain? Sometimes just educating the patients helps them uh, get over their anxiety a bit more. And as I said before, the multidisciplinary team involved includes a psychologist, physiotherapist, medical specialist, pain consultant, occupational therapist, nurses, pharmacist, and admin support. It can be delivered, PMPs can be delivered in a hospital setting or in a community. Usually a standard PMP program involves 12 half-a-day sessions. Okay, so the other aspects, there's a BPS guideline says the pain management program should be given as a complete package rather than individual psychological therapy or physiotherapy. And when it's given as a complete package, the evidence to support pain management program is quite high. So you've seen the practical approach or practical aspects of applying a biopsychosocial approach to pain management. From exam point of view, you got the slides to review for MCQ exams, and for Viva exams, for any of the chronic pain problems, if in the Viva they're asking you how would you manage the chronic pain, you can start with, I would approach using a biopsychosocial model. And then in the biological aspects, you can talk about pharmacotherapy and other management plans, and then include psychology and social aspects as well. So that will give your answer a rounded picture when you're giving a Viva. And that's it, everyone. Thank you for your patience.
Thanks, Arul. Thank